Welcome back, everybody. My name is Dr. Cow, and this is a series of specialty interview. And today I am joined by my good buddy, Dr. Tim Stevens. We went to medical school together. So welcome, Tim.
Thank you. Good to see you again, Con.
Good to see you as well. So he did general surgery residency, and now he's a trauma critical care attending. So he'll be talking to us about general surgery and critical care trauma. Welcome again, Tim.
Thank you.
All right. So briefly tell us your path to get where you are, and also describe a brief description of what you do day to day.
Gotcha. So I bounced around with choosing to go into medicine for a while. Even before getting into med school, it was kind of a late choice, kind of ruling out other stuff I thought I wanted to do. Yeah. But luckily ended up at the University of Cincinnati for med school. Loved it there. And then from there, kind of the same thing again. I didn't really have general surgery on my radar at the start. Was looking into some other surgical specialties. And it really wasn't till my third year when I did my surgery rotation that it seemed to click. A lot of people say you find kind of who you want to work with and who you fit in with, and that seemed to be the right fit for me. And again, that wasn't till the halfway through med school. So from that standpoint, I encourage everybody, don't be afraid to change your mind and take your time. It's stressful. Some people never know what they want to do, and that's okay too. Then for general surgery, once I narrowed it down to that, as far as residency, besides the match putting me where I wanted to go, I just wanted a high volume place that was going to make me confident when I was done and not close any doors. Ended up in the University of Tennessee at Chattanooga, which I didn't know much about, but I'm really thankful that that's where the match put me. Got an amazing training there, would go to there probably 9 times out of 10 again for residency. Similar trend, I didn't think I wanted to do trauma surgery when I started. I thought I was going to do probably colorectal or just straight general surgery, but when I did more of my trauma rotations, I really liked that aspect of it. I knew I liked the critical care side of it, but didn't think I'd like trauma, and it turns out I do. So once I figured that out, kind of focused more on getting prepared in general surgery just to be ready to practice and then find a fellowship for trauma critical care. From Chattanooga, I went to Birmingham for a 1-year fellowship. I just finished that up at the beginning of this year. Again, I loved it there. I went there because they're a very busy city, a lot of high acuity trauma, a lot of resources. And it was a 1-year program versus a 2-year program, which we'll kind of talk about in a little bit. Currently in Gainesville, Georgia, as an attending now. I've been working for about 4 months. It's great. Split pretty evenly between general surgery, trauma surgery, and then critical care. And depending on where you end up in your life, it can be a different balance of those 3 for your job.
Cool. Thank you for that. Now, I want to take us back to the medical school years where all of us have difficult times choosing what specialty to pursue. Like, what were the things that you thought attracted you to general surgery? And a lot of us, like myself, was like, I do not want a surgery life, right? It seems hellish.
I got you.
Yeah.
So I had it narrowed down initially to thinking of a surgical specialty like orthopedics or ENT, and then also for whatever reason, OBGYN. I did some volunteering before med school that I thought was going to put me down that path as far as like public health and things like that. And really for me, it was the experience with each of those. It wasn't necessarily that I disliked any of those rotations or interactions. I was just more of a connection to feeling more fulfilled during my surgery rotation. Yes, it's hard. It's probably the hardest I ever worked was as a med student on surgery of all times. And then, the big thing is obviously being comfortable in the operating room. Some people just don't like it in there, and that's fine. I like it. A lot of folks will say that they go into surgery because they like the immediate reward of like fixing somebody. I don't
Hmm.
know if that's really true for me. It's an added benefit, but I don't think that's what drew me into it. Um, and there are some harsh personalities in surgery. Those are kind of being phased out. They're still there, but I think you can find good mentors that um, kind of support how you'd want to run your career in life. And at Cincinnati, there's obviously a wide range of surgical personalities, but there are also a bunch that I felt like I could be like that person, or I want to be like that person. And I think when I started getting that feeling, like, in the future, I want to be like Dr. So and so, who's a surgeon. That really kind of was the point where it clicked for me and said, okay, that's what I want to do with my life.
Yeah, that's a fantastic decision process that you come about. A lot of us, you mean students, you mean we're not exposed to everything, right?
Yeah.
And a lot of us make decisions on what's in front of us and who we
Hmm.
interact with. If you had a bad surgery experience during your rotations, or no terrible uh, I wouldn't say terrible, but know of mean physicians. It just, it just brings you down the different path, and then not realizing there are great physicians out there of the same specialty.
Yeah. Yeah. And I think trying to weed out the bad experiences is the hardest part, and taking away the stress of, when I started doing rotations, I was so focused on trying to figure out, is this what I need to do with my life, that I kind of missed out on just enjoying the rotation as well, which is hard. I totally remember feeling that way and don't expect most of the med students to not. But,
Yes.
um, if they can try to make your focus on what am I learning, and, does this feel right, rather than is this what I need to choose, that might be helpful.
Hmm.
Um, and I think the hard thing is, if you have a bad experience, is who to talk to see if that's normal or not.
Hmm.
If you have friends that say, "Hey, I'm liking my surgery rotation, but you hated it," ask them what they liked about it. And it might be that they liked everything you hated, and then that makes your answer easy. Or, if it comes down to one individual, you could try to get some more experience outside of med school, or, retry it if you think it still might be an option.
Okay, awesome. Thank you for that. So, general surgery has a 5 to 7 year path. What made you? I know it's all about the match process, but
Mhm.
did you consider that as a, choice in your decision?
Yeah, it the I was prepared to undergo that length of training, and I looked at probably mostly 7-year programs and then a handful of 5-year programs. The main difference is the 7-year programs are generally more academic centers, and that includes dedicated research time.
Mhm.
And then, of course, I ended up at a 6-year program, which is fairly unique because
Yeah.
it's balanced between the two. Um, and that's a hard choice to try to figure out what you want from that, because most of the time as a med student, you're going to be coming from an academic center and that's what you know. Um, I think trying to choose where you want to go as far as training is going to be dependent on trying to make an educated guess as to what you want your career to be like. I really wanted to be confident in my operating abilities, but still have options to pursue just about anything as far as fellowships or getting a job near a big city or things like that. Um, and it's not to say that the shorter 5-year programs rule that out. Um, Oddly enough, one of our classmates, Wes Kim, he's doing his cardiothoracic surgery fellowship at Birmingham when I did my critical care fellowship there. And he was at a community general surgery program, and I was at this hybrid academic. So it's really how you want to apply yourself. I don't think there's any downside between the two, other than if you're really into like advanced research and you want that to be a huge part of your life, where you're pumping out papers and giving presentations, then you're going to want to focus on the longer 7-year pathway.
Awesome. Thank you for that. Because I personally don't know it. I can't imagine medical students know these things as well. Would you have done anything differently along this path to get to where you are?
Um, this is more of a personal response, but I think I would have been more forward about like making connections with people as far as like kind of career building, I guess. It's not something I thought about as I was training necessarily, or even not necessarily as a med student, but as advancing, just getting more comfortable networking, I guess. So I don't even know what that really means anymore, but um, I think that would have been a change I would have done. As far as the path I took, um, had I been able to decide earlier, I would have probably put in some more effort into like research that was surgery focused, or you know making my CV look nicer from a surgery standpoint. But otherwise, I'm happy with how everything's turned out. And like I've said, if as a student is going along their path and they decide something's not right or this isn't the right choice, it's going to be tough, but I wouldn't hesitate to talk to somebody about that. People change their minds during med school, during residency. It happens. And anymore, most places should be pretty supportive of you, of helping you find out what the right path is. It's probably a tough pill to swallow if you decide that what you thought you wanted to do isn't right, but you're not alone if that happens. Again, I wouldn't change, but I've come across residents and students who thought that they were going to be a general surgeon from the start, and this was the thing, and then at some point something just wasn't working. And then they were much happier once they found the next step. So don't be afraid to talk about that either.
Yeah, yeah. I like to piggyback on some of your comments, and I think it's very, very important to network with people. It's not we're not talking about kissing asses here. We're talking about finding mentors, finding people who can communicate to us what could be the next steps correctly, and also along the way maybe be able to be of value to them and also vice versa. And it gets you a long way. It has for me for sure because my work. Uh, Essentially, other docs that say, hey, they see I'm decently good person to work with, and they refer me to different hospitals, and that's how I've gotten my jobs. And so it's in medicine, it's it's a lot. You got to be competent for one, and then it's a lot of who you know as well.
Yep.
So what kind of personal qualities or characteristics makes for a successful general surgeon, and also if you want to touch upon critical care trauma as well?
Gotcha. Yeah, I think historically surgeons think they can pick out other surgeons in training. I think we had to take a personality test as part of our like medical school surgery rotation. And I'm sure that they try to peg you into one of the certain combos of letters that you're supposed to be. Um, I think overall, and this goes probably across the board, but someone who's going to be confident in their abilities and can take on a leadership role, um, and isn't afraid to make hard decisions. Work ethic is kind of cliche to say, but you and I were talking about this. We know how many hours you have to put in as a med student and a resident to go through surgery training. So you have to be okay with that. And not everybody is. I knew I was okay with that, still okay with that. As far as kind of personality characteristics, I mean, it's across the board. We talk about surgeons kind of being jerks and malignant, and in the past, that's probably more true. A lot of training places, as well as just hospital systems in general, don't put up with that anymore. And there's been a big swing in, not allowing that if it's not of any benefit. Now, I think you have to be able to tell people when they're not doing well as a surgeon, whether that's telling yourself or people you're working with, because like most specialties, you've got people's lives in your hands. And so you've got to have a lot of self-reflection as to what you need to improve on. So, I've encountered a wide range of personalities in training and residency and fellowship. So I don't think there's one box that you have to fit into. Um, I think if you can get along with other specialties, that's also very helpful because you're going to be interacting with who's referring to you, ER physicians especially. And then in the past, that's also, most surgeons hate their clinic and they don't want to do a lot of it, but you get a lot of personal interaction with your patients and their families. You're going to be doing tough procedures sometimes, you're going to have complications, and it's a lot more personal interaction than you might think. You might just have the idea that I'm just going to operate, do these procedures and be done, but there's a lot of one-on-one interaction with people too. So a lot of bedside manner still comes into it.
Okay, awesome. Thanks for that. You discuss regarding working in the clinic. What's your typical day like?
So my typical day, come into the hospital, and the way we have it split where I am is they kind of split the rounding responsibilities. Someone will round on the general surgery patients and see them, someone will round on the trauma patients, and someone will round in the ICU. And that's how it is most places. That's kind of the general split. I have clinic usually 1 day a week, which isn't bad. Some will have more, some will have less, depending on their volume. If I'm not on call, my day is usually done by 4 or 5. I try not to leave too early in case somebody needs help. And then as far as procedures, it depends on what kind of practice you go into. Where I'm at, most of it's more acute things that come in, whether those are traumas or general surgery cases, with a few planned scheduled cases. So it could be anywhere from, no cases each day to, 5 operations in a day, just kind of what comes in. And that's really personal preference for how you want to build your career. Some people like to operate all day, every day, and have a packed schedule, and some are more like where we're at, where it's what comes in acutely. Let's see, what else can I tell you about my day-to-day life?
Or like, what's the average number of hours you work?
Yeah, so it's probably like 40 to 50 in a week, plus some extra call. Where I'm at, we usually take call 1 night a week, and then, one weekend a month, which is really easy compared to training, compared to residency. What a lot of places are doing now, because they've realized that the prior way of surgical practice of getting work to the bone, there's been a lot of burnout. A lot of folks have hired on more surgeons so they can do a night float system, and they'll have one person do nights for a week or two, and no one's staying for 24 hours at that point. And that's just a way of splitting it and kind of sharing the duties that you have. So I don't think it's as bad as it used to be as far as, work hours and call and everything like that. And I'm totally happy with the amount of work I have right now. It's been great.
Yeah. So it seems like your general surgery is changing, so that way it's not such a terrible, from my perspective, lifestyle.
Yeah. Yeah, both in the training, the GME has done a lot to change how much residents can work, which is followed for the most part. But at least in surgery, it's a balance, because your chance to figure out how to do as much as you can before you're on your own is surprisingly limited in that 5 to 7 years. And so, you are going to want to really work your butt off as a resident, so that you're not going to finish and then realize, I don't know how to do this procedure, or I've never seen this before. There's still going to be things you've never seen before, but you'll at least have an idea as to how to take care of them. And I think that's been the hardest thing for some of the newer residents to grasp that I've worked with, is really comprehending how important it is to do as much as you can as a resident, and like see as much as you can. And I don't at all advocate people not having a family or social life. I've ended up with a wife and 3 kids through all of this, so like, it's possible. It's a balance, and it can be hard sometimes, but I think keeping in perspective the big picture of, you are a doctor now, and you're taking care of real people, gets lost sometimes in the, how much do I have to work, and what other things are going on perspective. But
Yeah, yeah. During residency, I would advocate whatever specialty you go into, work your ass off,
Yeah.
because at the end of the day, when you get that big boy job, you're it.
Right.
So, what do you find is the most exciting aspect of being a general surgeon?
Yeah, for general surgery, I like operating, obviously. I think that um, you don't always know what you're going to find. It's sometimes a surprise what you get into. You like to think you know what you're going to see, and sometimes it's total change. And I like being able to be adaptable and figuring out how to fix something on the spot. Um, and again, I was surprised by how much I liked the patient interaction and the one-on-one. You're getting a lot of trust put in you by these patients that you're operating on and their families, and that's a surprisingly strong bond that you get to build. Um, in general surgery, you could go and make your own career and specialize just in a few certain procedures or be a jack of all trades. And I think that's a nice aspect of it because it gives you a lot of options as far as where you end up practicing and how you want to build your practice. From a critical care standpoint, I like taking care of sick patients. It's a lot of good medicine base. And for the most part, with our surgery patients and trauma patients, we can get them better a lot of times. It's so frustrating sometimes if it's a lot of medical issues compounded on one another. It's hard to get those to get back to some sort of baseline, but we get a lot of good results with most of our patients. Um, and trauma is just an added bonus of you don't know what's coming in, and it kind of keeps things exciting. Some surgeons hate trauma, don't ever want to do it. Some
Yeah,
trauma surgeons hate general surgery and just want to do trauma. And that's the nice thing about general surgery is you get to eventually figure out how you want to do that. If you like the balance, you like one more than the other. And I really like the balance of all three, which is what I decided pretty early on.
cool, cool. And so, what's the percentage of people going to fellowship after general surgery residency?
Yeah, I can't throw a real number out there, but
Mhm.
that's a point of debate right now is how many people should be doing fellowship and how many shouldn't be, or who needs to.
Mhm.
There's a huge need for general surgeons straight out of practice. From a job standpoint, there will never be a shortage of that. That kind of comes down onto if you're trying to like stay in a big city or get into a specialty, then that's where a fellowship might help. But there's, great like middle of the road, smaller hospitals that need general surgeons all over the place.
Mhm.
And, specialty training kind of narrows your practice if you want to do. I know you've talked with some other classmates, plastic surgery, vascular surgery, one of those, you have to do a fellowship. You can still do some of those procedures as a general surgeon. It's just not going to be everything you do, and you're not going to do the huge things. And the point of debate comes down to some of the surgical specialties thinking that you should be fellowship trained to do their procedures, whereas general surgeons still want to do those procedures. And so, the biggest one that comes up a lot is with colorectal surgery is who should be doing cancer operations essentially.
Mhm.
Is that in the realm of a general surgeon still, or should it all go through a colorectal specialist? And the other issue that comes up with surgical training is are people going to fellowship just because they're not well trained and they're not ready? Um, like I said, where I did my training, I felt great. Um, I didn't have any concern that I needed an extra year as like a junior attending, which is essentially what some of these fellowships are, where you get a year of just kind of having backup around all the time. I think that's good that those options are there. Like I said, 5 years, sometimes you might not have learned everything you needed to learn or might not be ready. But um, so I think there's concern that too many people are doing fellowships. But I don't know what the right answer is from my perspective. I think if you need it or if there's a specialty you want to do, then it's there. But I think with most training you do, you could do your 5 or 7 years and be done and become an attending without an issue.
Awesome. Yeah, because it's a very long path already.
Yes, and there's so many pathways that I didn't even know about. And I think that's the hard thing with not just surgery, but again, as a med student, you might find a specialty you like, and then you realize, oh, I've got to make three more choices before I figure out what I'm actually going to do for a career, and that might change too. So, and that's okay. It's not uncommon for a general surgeon to have specialized in something, done their practice for a couple years, and then slowly back down and not do so much and only do some smaller cases and more normal general surgery and not even use most of their fellowship anymore. And so that's always an option too, is you highly specialize and then kind of change your practice as you age and evolve. And so there's lots of ways you can tailor your life with surgery. So
What do you dislike about the specialty in general?
um I don't know if I really dislike anything. I gotta think about that. I found it frustrating from a time standpoint that I was still in training, whereas people that like were maybe in emergency medicine were already attending, and I was still a resident. Um, I don't know if I disliked that, but as 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 a resident, when all of a sudden people you started your residency with are off getting jobs and you're still there for another couple of years, it kind of hits you in the stomach and the pocketbook.
Yeah.
um, that's not necessarily a dislike. Again, I think the time is necessary to be well trained as a surgeon, but it does come up. When you get into med school, your friends from undergrad will have gone off and started their jobs, and you're like, well, what the heck? I'm still a student. I'm not. When am I going to start my life? And then that kind of happens again in residency. But I knew that ahead of time and was okay with that.
Yeah, one thing I advocate to everybody is that you can't really compare yourself to others. You just have to focus on your path and
Mhm.
know that you've accepted your path and hopefully be happy with the choice you make.
Yeah.
So no other thing about like what I mean, general
Yeah, I
surgery. A lot
think
of people say, oh, you mean they work so hard, they're under stress a lot. There's a lot of maybe lots of lawsuits or something like that, or
knock on wood, I haven't been sued yet, but
yes,
I'm early in my training. I know it
yes.
will happen. I think, yeah, that is a concern is kind of litigation and stuff, and it's going to happen. You just want to have support of where you work. Um, I don't think that would have pushed me away from surgery.
Mhm.
I think one thing that's probably not totally unique to surgery, but can get frustrating is sometimes if you get stuck late at the hospital way past your shift. And usually, even as a resident, but especially as attending, it's not for doing like paperwork or dumb things. It's usually because you're actively having to help somebody, which isn't bad. But if you get a bad run and someone sick comes in right as you're about to leave and you have to do an emergent operation, again, I like doing that. That's part of why I picked this, but it can wear you down a bit when I thought I was going to be home early afternoon and then I'm not getting home till, middle of the night or things like that. Um, and then depending on how your call is set up, so I take call in the hospital.
Mhm.
Some surgeons do home call, and you think that's great, but that can be pretty frustrating too. You'll drive into the hospital, however far away you live, spend an hour seeing a patient, and then drive home. And you've wasted, 2 hours of your night to do nothing. The balance of that can be a bit up and down. I think finding what works best for you makes that easier. But I think some of the unpredictability in the schedule can be a pretty big downside for some folks.
Awesome. So let me see. So how has general surgery or trauma have changed over the years and in light of COVID-19 as well?
Mhm. Yeah, so as far as over the years, technology is obviously changing in medicine constantly. Robotic surgery is huge now. I do robotic surgeries. I'm sure there will be a new innovation around the corner from that standpoint, which is part of what I like. It's usually the same basics of the operation. You just find either a better or a new way to do it and which way you like to do it, which is fun. Um, Again, we kind of talked about the fellowship choice. I think that has been a change as more people are doing fellowships. and trying to figure out if that's the right choice for what the healthcare system needs as a whole. Um, Trauma and critical care is constantly changing. I like that about it, but it's a lot to keep up with. The evidence-based medicine that we use to take care of patients is often found to be wrong after a couple years, and then all of a sudden you change everything how you do, like a complete 180. Lots of examples of that in surgery as far as how we resuscitate patients and take care of them from a critical care aspect. So it's a lot of active learning to keep up with that. Again, we kind of talked about how a lot of the negative personalities are probably getting phased out. They're still there, but that's not as typical anymore. There's, again, more attention to a work-life balance. People realize they can't keep turning over surgeons in their practice because they get burned out and have to go somewhere else. So that's improved. COVID hasn't really affected trauma or critical care because that still happens. And acute care surgery, which is generally emergency stuff that comes in, hasn't necessarily changed, but it has put a big hit on elective procedures. And that's kind of across the board just because it wasn't safe to be doing those. And I know in searching for a job, a lot of places were looking for surgeons and then had to put that on a hold because they were taking big financial hits because of COVID-19. That's not true for every hospital system, but there's a large number that just are trying to be safe. They don't want to have a huge catastrophe because they've hired too many people. I don't think that's going to persist. A lot of places have found a way to keep doing some of these procedures and kind of gotten back on track. On that same aspect, I think another one of your questions is about the job market. And I'll just hit that because that kind of flows into it from COVID-19.
Yeah.
Like I said, there's always going to be a need for general surgeons. There's been studies and presentations about the value a general surgeon brings to a community and a hospital. So there's never going to be a shortage of job options. Like I said, it's just harder sometimes if you are, you want to be a general surgeon at the main hospital in New York City or, Chicago. Those, obviously everybody wants to do that. Like, it's the more competitive places are going to be harder to get into, as simple as that sounds. But there's always jobs everywhere. I'm still getting emails and phone calls about, oh, do you still need a job? Can you come work for us for a shift? There's locums work too, like what you do for surgeons. There's a ton of places that are short on surgeons. And if you're not sure where you want to end up, you want to, work at a couple different hospitals and maybe eventually people stay on when they do that, that's an option too. So I think that answered those questions.
Yeah. As some of you guys know, I do locums. And I was blown away when I met like a locum surgeon. I was like, what?
Yep.
How's that even possible? But he seemed to love what he does because all he does is just, be on call for the surgery and not the clinic aspect.
Yeah. Oh, and then one other change that kind of ties into the specialty and maybe jobs is, there's just, and I wouldn't focus on this as a med student because I didn't care about reimbursement or my taxes or anything crazy like that because I was too busy worrying what the heck am I going to do with my life. But always good to be aware of these things because you'll hear people talk about them. Currently, most of surgery, as far as your salary and payment, is based on like your output and your procedures. And there's been talk for a couple of years now, and it'll probably happen, of changing that to more of, instead of a fee for production, of being more of a quality based, which is not just in surgery, that's happening everywhere. All the quality metrics that hospitals follow and have to report. I don't really know how much that would change the specialty as a whole, but that might be a big change that happens soon. It's just, instead of being focused on how much you do, being more focused on how good of a job you're doing it, which isn't a bad change. It's just a big change.
Yeah. And the multiple specialties that I've talked to are saying that's happening in their field as well.
Yeah.
Cool. Thank you for that. Do you work with mid-levels such as nurse practitioners or PAs? And then how do you see their roles changing down the road?
Mhm. So in residency, we only had a few, and that was just to help out. Everything else was basically on the residents, and that functioned fine. Where I did fellowship in Birmingham, it was so busy and such high volume that it would have been too much for just the residents, even though they had so many. So they had a large number of MPs and PAs that helped out, and that functioned really well. That was kind of an added bonus of that fellowship is I hadn't really worked that much with mid-levels until then. Um, where I am now, we also have a large number of mid-levels. We do have residents, but we only have 2 classes right now, so not enough to really shoulder that workload.
Mhm.
Um, uh, Unless you're in a center that is always going to have a huge group of residents, you're going to have mid-levels working with you as a surgeon. It's just too much to handle all of the patient work on the floors and the wards and operate and do clinic and do things that come in on call. A few smaller hospitals are just the surgeons, but I don't really see that changing because it functions well as as a team that way. Um, and I think that that was something that I learned during fellowship is that it's a really good team that you can build with mid-levels and surgeons and residents if you have them. And I think it functions well overall. So I don't think the responsibilities will change necessarily. I just think that that's always going to be there. I think it's something that is beneficial, at least in the surgery world.
Okay, awesome. What additional resources for students who want to learn more about if general surgery is a good fit for you or critical care trauma?
Yeah. So there's a lot of different surgery groups out there that you can join, and most of the time as a student, it's free. Um, there's the American College of Surgeons. There's a surgery critical care medicine group if you're interested in that. Um, there's the SAGES group, which is general surgery. Those have a lot of resources as far as looking at what the careers are like, what's changing. Um, Trauma specific, the 2 main ones are the East Trauma Group and the West Trauma Group, basically split half and
Yeah.
half. And kind of going back to the networking thing,
Hmm.
um, general surgery and trauma specifically are surprisingly small little worlds once you get to know people. And the meetings that are put on by the trauma groups are very open to having med students come and med students participate. Obviously, with travel and cost and stuff, it's not accessible for everybody. But even if they're putting on a podcast or anything about it, or a video review or something, I'd take the time to look at that because that'll get you an idea of what we focus on as a specialty as far as what we're looking at as research. And the research isn't just always clinical stuff; it's also looking into our work-life balance and how we're training residents and things like that. So any of those groups are usually very open to having med students join them, and you'll get all kinds of paperwork from them and things to read and try to keep up with. Um, as far as resources outside of that, don't hesitate to ask a resident or an attending for advice. Like we've talked about, there are still some harsh personalities, but you can even learn stuff from them.
Hmm.
I've learned a lot from some of the harshest personalities I've encountered. But for the most part, everybody just wants students to end up in a specialty that they're happy in and be able to do well in life. So it might seem intimidating to ask an attending surgeon that you're around for advice or if you can meet with them, but the worst they can say is no. I'd be surprised if they say no. And the best thing that can happen is you have a new mentor and they can talk to you about stuff. And like I said, the large majority of us will gladly talk about things and let you know what goes on in our day-to-day life and get you connected where you need to go. So um, I wouldn't hesitate to ask somebody.
Okay. And then I have two more questions. What are the myths of general surgery and trauma and critical care that you think are unfair or untrue?
Gotcha. We kind of touched on some of this. I think the lifestyle's improved. So,
Mhm.
the old myth was surgeon just works all the time, has no family, hates life. It's really not like that the large majority of places anymore at all. And again, it used to be surgeons are going to yell at you and throw stuff in the operating room and break things and have tantrums. That still happens, but again, that's not common. And I think as you do your rotations, like it'll be put into perspective, hopefully, is most of the time when people lose their calm, it's because something bad is happening to a patient. Sometimes it's just because they're princesses and they need everything given to them on the spot. But for the most part, the stress of some of the operations we do and people we take care of, I think it gets to everybody at some point. I'm generally a very calm person, but I've been pushed to my limits here and there, I will admit that. But it's not as bad as I think some people make it out to be anymore.
Yeah, I'm glad it's changing for the better.
Yeah.
And for everybody, you, patient care, students.
Mm-hmm.
And so my last question is, you've given lots of great tips to students. Do you have a number one tip for them?
I don't know if I can narrow it down to number one.
Or okay,
I'll probably give you a handful just because I don't know if any of these is more important than the others.
All right, let me read the question.
No, you can know, that's fine. I just I think that some of these are basic things, but the stronger you set yourself up, whether that's with your test scores, getting reference letters, the easier your path will be into any specialty. The competitiveness of surgery kind of goes up and down, especially with where you want to end up. So the easier you make that path from that standpoint, the better. However, if you have trouble in one of those aspects, that doesn't have to be the end of your route. Always be prepared to adapt from that standpoint and bolster yourself up better. And that's where the networking comes into that we talked about. You can get your foot in the door in a lot of places if you know somebody or have someone to vouch for you and say, yeah, their test score this one time sucked, but they'll do a great job and you should take a look at them. That happens, and that's how it should be. I think if as a med student and you're wanting to do surgery, the best tip I can give you is to always try to perform one level above what you're at. So if you're a third year student just starting your rotation, you want to try to be recognized like you're already a fourth year. And when you're a fourth year doing clerkships, you want to try to act like an intern. And most of that comes down to being available and really taking ownership of your patients as you're on the services. Know the lab results before the residents know them. We're not going to expect you to know every detail of a procedure we're doing, but show that you cared enough to be prepared, and that will go longer than anything else you do. Is just making it clear that that's why you want to be there. And even if you don't want to be there, if you want to do well on your rotation, you should probably do those things too. But
yeah,
if you realize it's something you want to do, just take the extra effort to show that you're interested.
Awesome, thanks. I think your tips are very, very valuable to the students. I'm not sure if you're aware, but they're going to make step one pass fail in a couple years.
I'm aware. I'm not happy about that.
We studied so hard
I know.
for that stinking exam. But yeah, who knows if it's a good thing or a bad thing, because you got to be able to somehow differentiate students, how well they study, but there are other qualities that students should spend their time on learning as well.
I agree.
Yeah, so that ends the questions I have. Do you have anything else to input? I think you've given a lot of great advice.
I'm just trying to think if there's anything I missed or that I really want to make sure they hear about. No, I think it's okay.
Okay.
I don't know. Do you think I missed anything?
No, I think
I think so. Okay.
no. So thanks again, Dr. Stevens or Tim, for your valuable contribution, and hopefully the students will find this of value. I know I did, and I wish I had these kind of talk when I was a medical student.
Yep, and again, I thank you for getting these together. I think it's a great resource for people. And again, just want to reiterate, if a student has a question, feel free to ask, any specialist around. And most of the time we remember what it was like to be in your shoes, and we can try to help you out.
All right.
All
Thanks
right.
again.